And most importantly to all this, right, our echo techs and other providers that help us with image acquisition. And so I'm very happy to go over this and give an update. And so my intent here is to talk maybe 30 minutes, and then Dr. SU MIN CHANG will take the lead about really putting all this together in terms of imaging, including the role of CT to help us manage these LVAD patients. So just for those that aren't as familiar with the current LVADs we're using, there are now 3 pumps approved for bridge to transplant. Our workhorse for several years has been the HeartMate 2. And a common denominator for all these pumps that assist the left ventricle, there's an inflow cannula that enters the left ventricle. And so blood is sucked into the pump. There's 2 types of pumps, an axial flow and centrifugal flow. These axial flow pump, blood comes in and is parallel to the rotor and propelled to the ascending aorta. For the centrifugal pumps, blood comes in and leaves at a right angle, but propelled to the ascending aorta. This configuration is true for 99% of all the current LVADs. The HVAD more recently, this is a little bit dated, this past year was updated, the end of this past year was updated and has approval for destination therapy. So there's the HeartMate 2, typical operating pump speeds are around 8,800 up to around 10,200. The HVAD, typical operating pump speeds anywhere between 24 up to 2,800. And the new pump on the block, so to speak, is the HeartMate 3. And it was more recently, the end of this past year, approved for bridge to transplant. Still undergoing follow-up in the Momentum landmark trial with anticipated requests for approval for destination therapy, I would estimate by no later than by the end of this year, but more to come in that regard. So this is a pump adjacent to the left ventricle, so it's intrapericardial, much like the HVAD. It's centrifugal, much like the AVAD. Different from those pumps, it's maglev design, true maglev, and there's wider gaps, and this pump speed decreases and increases on its own and creates washing out of the pump. And so it's been a game changer, at least in a short-term bridge strategy without pump thrombosis based on the preliminary evaluation. And so those are the 3 different types of pumps. And it's important when you're going to image a patient, and I'm going to focus in on this in the end, is okay, this patient has an LVAD, a left ventricular assist device. What kind of LVAD do they have? We have 3 that we're commonly using, HeartMate 2, HVAD, and HeartMate 3. And certainly the request is to put that on the echo report in addition to the pump speed. And then know why we're doing the test, right? And then an interpretation based upon the indication, and that's going to help us most clinically. Now, we created, I had the privilege to be co-chair and working with Dr. Steinbeck to create this ASE guideline document. This is very, very comprehensive in terms of image acquisition, the role of echo with clear definitions, and how it helps us from a management strategy. So please use this as a reference. Today, what I'd like to do is focus in on these 5 clinical scenarios, and I will highlight the desired echo report based upon a clear indication to help us troubleshoot. And so that's the goal for this portion. And so I'm going to start off with RV failure, and I'm going to give you an idea of the prevalence of the problem. And RV failure, certainly we're always concerned about it happening early, but late RV failure is a much more recognized profile. And the working definition we use is one based on clinical grounds of high CVP and surrogates based on exam. The most specific definition is when they need an RVAD after surgery, and that's typically, we see it either intra-op or early postoperatively. But needing inotropes for more than 2 weeks is part of this RV failure definition. What I would highlight is that there is a spectrum of RV failure, and in the echo lab, you're going to see that. So the clinical grounds of prolonged inotropes or needing or impending RVAD is certainly those we're worried about most. When you look at clinical trials, prevalence around, in terms of needing an RVAD unplanned, around 4 to 5%, prolonged inotropes, perhaps another 12 to 13%, so about a 20% likelihood of either prolonged inotropes or RVAD need based upon some of the landmark trials. And when you look out to data out to 2 years in terms of this concept of late RV failure, coming in outside the 30-day mark post-implant and needing inotropes or having overt clinical signs of RV failure, and this is based on an endurance trial which looked at HVAD and the HeartMate 2, which was the control. Prevalence up to as high as really 20, 25%. And so we're certainly seeing this more commonly. So this is an example of a patient post-LVAD. And on the front end, the number one cause of RV failure is left-sided heart failure. And many of our patients have a dilated RV, not out of proportion to the LV, and they have compromised systolic function in the context of depressed RV. And so we're going to be very focused in on certainly the overall appearance by echo, including the left ventricular septum, the interatrial septum as barometers of pressure gradients across these structures. Because what's new for this particular patient is an inflow cannula, again, sucking blood and propelling it to the ascending, which can influence those gradients. Let me come back on. And so that seeing compromised RV systolic function or a dilated RV needs to be put in context of certainly what the LV looks like, and most importantly, the clinical scenario. So let me show you a more overt or more severe spectrum of RV failure. So this patient was postoperative day 3 and had low flow alarms, which has a differential, one of them being RV failure. But what you can appreciate from the peristernal long and the off-axis forward chamber is the LV is very, very small. The RV is significantly enlarged. This is flow from the inflow cannula, again off-axis. But appreciate the big right atrium, slit-like left atrium, a very underfilled LV, and the absence of a pericardial effusion, certainly in the presence of the clinical profile of hypotension, low flow alarms, this is emergent. And to be honest with you, clinically, the differential is tamponade versus RV failure, and echo helps us to distinguish that. We go and we typically can measure or appreciate high CVP and hypotension, but these patients may not need an upfront RVAD. We can do things clinically like lower the pump speed, put them on inotrope, or afterload reduce the RV with nitric oxide. And so we can help many, many patients understanding the contribution to the profile as it relates to RV failure and tamponade. This is an example of someone requiring prolonged inotropes without hypotension, but certainly higher CVP. You can appreciate the LV is still small. The aortic valve is persistently closed. Here's the inflow cannula nicely positioned. But the RV is dilated and depressed and residual TR. It's our practice, historically has been our practice to prepare tricuspid valve, the tricuspid valve in the setting of moderate or more TR on the front end. When you look at larger studies, that's not that's certainly not a widespread intervention, because the thought is if you can mitigate or minimize left-sided heart failure, you can minimize the congestion or compromise of the RV on the back end. And so, but we see this phenotype quite often, and this is still potentially very workable. This is an example of someone with a late RV failure phenotype with several months after an LVAD, interventricular interdependence, and it's only with ventricular systole do you see that ventricular septum bow over to the RV. High right atrial pressure relative to an unloaded left ventricle and left atrium, with the interatrial septum bowing over into the left atrium persistently, and stigmata for high right atrial pressures by echo and significant TR. And so this can be very, very challenging. They're several months out, and we certainly try to optimize blood pressure, pump speed setting, and preload with diuresis, but many of these patients need a heart transplant. And are doing poorly in terms of long-term survivor. And the prevalence of this being currently, based on current studies, estimated about 10 to 12%. So I'm going to transition into troubleshooting that helps us inpatient. And I would say the most worrisome finding, at least in terms of what the console has given us, is low flow alarms. And I'm going to go over that and show, again, highlight how echo helps. So here is an actual patient. This is the posterior belly, anterior belly. Here's your CVP. So who thinks the CVP's low in this scenario? Just raise your hands. Who thinks the CVP is high? Yeah, so perhaps you can't see as well. I want to include a moving image. I was so proud to have a moving image of a true CVP. CVP is high. This negative, negative, negative for the HeartMate 2 is a low flow surrogate. We can interrogate this device, and it's clearly a low flow situation. And in that scenario, this patient's on the floor outside in the intensive care unit. But the concerns here would be RV failure, pericardial effusion and/or tamponade, dysrhythmias, hypertension after load for the pump, to name some of the common findings. Hypovolemia, you wouldn't have a high CVP. But echo is going to be very useful here. Now, certainly we check blood pressure rigorously in this patient population, and we understand rhythm burden at the time of that evaluation. Well, let's look at the echo in terms of how to help this. Yes, there is a pericardial effusion, perhaps some organized clot, but this is the LV, and appreciate a very, very underfilled LV in the presence of a dilated RV and significant compromise in RV systolic function and significant TR. So the contributor to this patient's challenge at that point in time is RV failure. And so we had to certainly resuscitate the patient more urgently by lowering the pump speed, place the patient on a trope. And this was just a temporary mitigation strategy, because this patient ended up eventually having an RVAD in the setting of a reoccurring VT VFib, which further tanked the RV. And so echo really helps us in the acute setting to troubleshoot this patient population. Here's another patient I saw in the intensive care unit, was only a few days out, was having some pre-syncope, was standing, and had intermittent suction events and low flow alarms. So who would care to render the diagnosis based on that? High CVP, the clinical scenario I mentioned, and so it's the same differential. But you can appreciate pericardial effusion. It can be hard to see chamber collapse, but certainly when you have a continuous flow pump in a smaller chamber to begin with and a pericardial effusion, you want to take this out of the equation to help manage the patient, which was the case. And even though they have compromised RV systolic function and a dilated RV, the primary issue here was not RV failure and was tamponade, which improved significantly with drainage. So certainly keep this algorithm in mind for high CVP, low flow alarms, whether it's with or without hypotension, using echo to understand these three scenarios: RV dysfunction, tamponade. Inadequate LV unloading is less commonly seen, but we may need to augment the pump speed to minimize heart failure, to improve upon blood pressure, but that's much less frequent of a problem. So let's transition to the second clinical scenario that I think is quite common, and that's persistent heart failure. And so the purpose of the LVAD is to create heart failure remission, right? It unloads the left ventricle, subsequently the left atrium, minimizes secondary pulmonary hypertension. That, for 75% of our patients, creates a class 1 to 2 scenario. We're not curing heart failure, right? We have an assist pump that's minimizing the syndrome of heart failure. But the reality is heart failure readmissions post-LVAD are not uncommon. This is from the Cleveland Clinic and Mayo groups. You can appreciate smoldering heart failure prevalence as high as 15 to 20%. And when you look at clinical trials, persistent New York Heart class 3 or 4 is as high as 25%. And that certainly can be influenced by comorbidities. But I would think that inadequate LV unloading is a contributor to some of those patients. So here is a summary of the echo features consistent with inadequate LV unloading. And the aim here, right, is to create a wedge under 15 or 18. I wouldn't get too caught up in that cutoff, but try to create more of a normal wedge. Persistently dilated left atrium. It's very unusual or less common for us to see significant secondary persistent MR when we have the pump speed setting adjusted and are controlling the blood pressure. Seeing estimated PA systolic pressure readings above 40 would be a red flag for us, especially if coupled with elevated right atrial pressure clinically or by echo. So you can appreciate that by these two pictures. Now we, years back, were very interested in understanding which echo parameters were best, both in terms of feasibility of looking at that variable to predict wedge greater than 15. So we carried out this study in 50 patients and defined the AUCs associated with wedge greater than 15. And in the end, we ended up coming up with an algorithm that mirrors the current ASE guideline algorithm, which is very helpful in many ways, as it relates to looking first at mitral EA, because we didn't really know how continuous unloading would affect these mitral valve parameters. And it turned out that mitral EA, very feasible in this patient population, looking at estimated RA pressure, systolic pulmonary artery pressure, left atrial volume index, and EE prime. Was very useful in terms of detecting a patient having a residual high wedge we defined as greater than 15. And so this is most important for those patients that have persistent high-grade symptoms or in the hospital, perhaps a difficult exam with shortness of breath. We're trying to judge the adequacy of LV unloading by pump speed setting, blood pressure management. And so this, I think, is very familiar to you all in terms of EA less than 1, and EE prime less than 14, a systolic pulmonary artery pressure less than 40. This would be adequate unloading on an LVAD compared to someone with more restrictive physiology or persistent significant pulmonary hypertension. And so the differential we go through in our mind when we're convinced that there's inadequate LV unloading, and echo is first line. We rarely these days take someone to right heart cath when we can judge the adequacy of LV unloading. It's, do we just simply need to be more aggressive with the pump speed? Screen for hypertension, and we are very aggressive with understanding blood pressure in this patient population because it is afterload for the LV. And so we use the Doppler method, and I'm not going to go over the details. I think the fellows are very familiar with this, and this is recorded in the chart. But also we're considering outflow cannula kinking, inflow cannula malposition, rotor thrombus, continuous aortic eye, as possible, the possible underlying etiology that accounts for the heart failure syndrome. So let's walk through inflow cannula positioning. This pump, this inflow cannula, should be pointing towards the mitral valve apparatus, right in the middle of the left ventricle. The challenge is many of these hearts are overtly remodeled and look like a basketball, and so the surgeon's trying to define true apex. And there's different techniques that help them, but it can sometimes be off axis. It can be very workable on off axis, but for some patients it's not. So in the ideal scenario, the inflow cannula can be appreciated on short axis, as in the middle. You can use color Doppler to understand its location at the apex. The Doppler profile is defined here. And remember, it's a continuous flow pump, but it's really an assist pump. And most patients still have some native LV contractility. So we see partial flow generated by the LV through the pump. And that is non-obstructive. And remember the Reynolds number as a poor man's screen for aortic stenosis. It should be under 2 meters per second. To be honest with you, it's typically under 1.5 meters per second. But you can use off-axis imaging to understand normal flow through the pump. Here's an example of an inflow cannula pointing toward the distal anteroseptum. Remember, this is anterior, this is posterior. This is very anterior. And this patient was having reoccurring non-sustained VT and suction events and had obstructive physiology. This was not workable long-term, and he ultimately underwent heart transplantation. Here's an inflow cannula. It's more, so remember the apex would be here. This is already more posterior, and you certainly can appreciate that, getting closer to the base of the heart. It was actually causing problems with tethering of the posterior mitral valve. And this was associated with significant mitral regurgitation. So in this particular patient, it was clear that the patient was in persistent clinical heart failure. So we really had to take advantage of this concept of testing at different pump speeds. And when we want to optimize heart failure, it's subtle speeds. Here I'm showing you 8,000 to 11,000 for the HeartMate 2, but we go up in increments of 400 revolutions per minute, because what we don't want to do is create a scenario of excessive LV unloading. So our goal is to minimize the LV as best we can, but the real primary focus here in the setting of significant MR is creating a scenario of less MR without over unloading with small LV and suction events. So this patient ended up doing well, albeit at a higher pump speed setting for years from New York Heart Class 4 to New York Heart Class 2. This patient had a perfect inflow cannula, and despite aggressive blood pressure control, had significant MR, and really similar concept, needed a higher pump speed setting to minimize the persistent heart failure in the setting of persistent secondary mitral regurgitation. When we can't resolve this issue by non-invasive testing alone and by exam, we take the patients to the cath lab. This is a forest plot where we look at right atrial pressure and wedge and output. The goal for these heart failure patients to keep it easy and construct is to have a normal wedge and a normal CVP. Some patients have biventricular overload where their wedge is high and they have secondary right-sided heart failure. And our goal is to try to get them to this zone. Some patients have that late or early RV phenotype where the left side of the heart's unloaded, but they have high CVP and are predominantly right-sided heart failure. Increasing the pump speed is not going to help that scenario. In fact, it can hurt or worsen that scenario. So we go to the cath lab and we change the pump speeds to try to achieve normal filling pressures on the left and right side of the heart. And we're also taking into consideration output. Our reality, whether it's the HeartMate 2, the HVAD, or the new pump on the block, as I mentioned, the HeartMate 3, is really the minority to mild majority, flip of a coin, of patients having both normal wedge and normal right atrial pressure. Most of these patients are partially unloaded. And now it's an improvement compared to where they started before the LVAD, but many, many patients potentially can be helped by speed optimization. And so I give you an example of our protocol, and I think the techs are certainly very familiar with this. Certainly when we're coupling it with right heart cath in the lab, but we're increasing the pump speed or decreasing increments of 400 for the HeartMate 2. This should be updated for the HVAD, and for the HeartMate 3, it's in increments of 100 revolutions per minute. So here's an example of a patient that was about 3 weeks post-op, persistent shortness of breath, high CVP, and 3+ lower extremity edema. Here was the baseline pump speed. LV is still big. The LV is not ejecting above that level of pump speed. The aortic valve is persistently closed. There's no AI complicating the heart failure persistent phenotype. MR is not that bad. And so with pump speed augmentation in increments of 400, here's the inflow cannula, reasonably well positioned, even though it's directed towards the septum. We don't appreciate any suction events clinically or visibly by echo. We ramped this patient up to a pump speed of 10,400. Now the LV is still big, but it did reduce by about 0.4 centimeters. We don't know what the magic cutoff is for that patient population. We really have to tailor it to that patient individual. This is under active investigation. And really it was only in the cath lab where we were able to demonstrate significant reduction in wedge and over time right atrial pressure. And so the instantaneous changes in looking at the mitral valve indices and the Doppler parameters still is not there yet with enough sensitivity and specificity for us to optimize with echo alone in some patients. Other patients it is. And so this particular patient at 9,200, the wedge was 25, and at 10,400, wedge came under 16, which is under 18. And the patient did well for over a year. Ended up having recurring heart failure for other reasons other than pump speed. And in many of these patients, you can augment output or index by increasing the pump speed. But the surrogate, the goal is filling pressures. Certainly perfusion is important, but I would prioritize filling pressures. I'm not going to talk a lot about A. I want to show you some about aortic insufficiency. I want to show you a few pictures. Yeah.
What's the end point for quote-unquote optimization? I'm going to think out loud.
Yes.
Can I do a parasternal long? Okay, I'm trying to be practical here. Parasternal long, looking at the aortic valve, AI, a relation of RV size to LV size and mitral regurgitation. I get everything there. You could do that with a V-scan at the bedside, pump, 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 you're gone. You could do it almost every day, and it takes 10 minutes.
So I think you're right on in that if I had to pick the one view that gives me the most, it's certainly the peristernal long. Now the interatrial septum, interventricular septum, an apical view can help in some scenarios. But yes, one could come up with a tailored protocol, if you will. And over the years, we've done that, but not quite to that one view. We used to get full echoes on everybody at different pump speeds. You remember the craziness, and that creates a hour plus time commitment from the tech, and then another more than 30 minutes for the person reading it. So we get focus views related to optimization. It's peristernal long and apical 4, and those typically help us the most.
But what I'm thinking of is the primary goal some opening of the aortic valve, certainly not at the expense of small LV and a big RV. And if MR
Correct.
is an issue, obviously you want to decrease it. But these are the
Yes.
these are the variables.
So for optimization, the primary goal is to tailor that echo surrogate that's reflective most for high wedge for that particular patient. So if peristernal baseline shows high-grade MR, you're going to tailor it to MR severity reduction. If the LV's big, you're going to incorporate LV size reduction. Aortic valve intermittent opening is a secondary aim. Our goal is to always minimize the heart failure phenotype. If we can keep the aortic valve opening intermittently, that's great, we think, and I'll define why, but that's secondary. So to answer your question as clear as I can in terms of prioritization, I would say it's MR severity and LV size, and being cognizant of RV size and function relative to these pump speed changes. So that's a very good question, and as it relates to AI, we're very clear on the front end. Those with moderate AI we're very worried about. When you activate the pump, when you reduce LVDP, you can bring out what was suspected to be mild to moderate AI, and it's actually worse because of the grading across the aortic valve. And so this typically will need to be taken care of clinically. But this can develop over time. This is an example of our patient 1 year after LVAD, right? We're now having these annuals with LVAD, which is great, much like heart transplant. And LV is normal size. There's aortic valve opening and no significant AI, right? Maybe some trivial AI. And at year 2, LV's dilated. Patient's having symptoms of heart failure. This eccentric, right, continuous regurgitant jet. And we augment the pump speed, control blood pressure. You don't need to be an expert echo interpreter to appreciate the big LV, continuous AI, right-sided heart failure, this high right atrial pressure with flow reversal in the setting of persistent left-sided heart failure. And so when you're judging AI, it's in keeping with the standards that are created for patients with heart failure in the absence of an LVAD, but it can be difficult because of the eccentric nature. But cognizant of LV size, significant AI, LV will dilate even in the presence of an LVAD. That's a take-home concept. And this is a problem up to as high as 25 to 30% of patients in terms of echo features. Clinically significant AI requiring for us to do something is a lower prevalence, probably on the order around 5% based on our institution. And so we always screen patients not only by echo, but by the presence of heart failure or not and how big the LV is. And that particular patient, just to close the loop, needed surgical closure. Ended up doing well for another year. Was on device support for about 5 years. But heart transplant is the best fix, if you will, for this patient population. So given the time, I'm going to go over a couple more of the troubleshooting, because I do want to get to the templates and to the acquisition. And the goal for these patients is to anticoagulate them, typically 2 to 2.5 for both the HVAD and heart rate 2, out of the box certainly 2 to 3, because we want to avoid ischemic stroke and pump thrombosis, thromboembolic sequelae. And so these clots can form due to lack of coronary runoff in the coronary cusp. This can sometimes be difficult to appreciate by transthoracic. TE can help. And SU MIN Chang is going to highlight the role of CT in this scenario. To screen for hemolysis, we have a very aggressive protocol where we know their baseline LDH. That's the best parameter with the best sensitivity and specificity to detect hemolysis for these LVAD patients. Clinically, if you're having hemolysis, they can get dark urine. If the pump's not working, they can get clinical heart failure. If you have a clot on the rotor, power consumption will go up. For it to have to spin to the same degree with that obstruction, power consumption will go up. So we look at all this clinically. This was a proof of concept by our Mayo colleagues, and probably the first echo sign is you get a decrement in the diastolic peak flow because the pump's not working as robust as it was. The LV contribution or the peak systolic remains the same, but this ratio increases. So they looked at patients at baseline compared to presentation with clinically proven hemolysis, enhanced anticoagulation with subsequent reduction in the ratio. So that's one role for looking at apical inflow velocities as it relates to hemolysis screens. Now we're looking at LDH, so I don't want anybody to think that the echo screen is trumping the biochemical screen in terms of LDH. But more important than that, I think for echo in terms of this hemolysis story, we want to know if the pump's being affected in a way where it's not working as well. The obvious one was patients are in clinical heart failure. But if we see pump malfunction demonstrated by echo, we're much more concerned that we're headed towards replacing the pump or needing transplant. The likelihood of salvaging that environment and getting rid of that rotothrombus is much less likely. So my colleagues at Columbia and Ariel put this concept forth, and really very simple concept. When you ramp up the pump speed and look at several echo parameters, what they observed is that the LV didn't shrink as much. And so this is a patient with pump malfunction in the setting of rotor clot compared to someone that's normal. And they get multiple LV dimensions, that's several pump speed settings. And they actually plot this on a spreadsheet and they give you a slope. So I think that's very useful. And we've made it much more simple, albeit in a sicker patient population, where we looked at a cohort of normal versus true hemolysis with suspected pump malfunction. We looked at all the echo parameters, and there were 4 that had blunted response. So here's an example, and really I want you to focus in on aortic valve opening. Pretty good underlying heart function. In fact, this patient had an explant from Texas Heart. But when you crank up the pump speed, the aortic valve becomes persistently closed. That's true for the vast majority of patients, even with good or reasonable underlying LV function. That's in contrast to someone with a rotor clot. Aortic valve's opening at baseline. Certainly, if it opens at baseline, it's going to open at lower pump speed. But at 11,000, it's still opening. And that LV is, you can do the measurements, is just as big. That's telling you that there's something with the pump, conceivably something with afterload with hypertension, but we know that clinically, whether that's an issue or not. And so we have defined these 3 parameters: persistent aortic valve opening. You don't need M mode, but this shows the story nicely. A blunted prolongation of the deceleration time, and persistent significant, the lack of LV reduction in terms of size, low and high speed. So instead of doing 12 measurements from 8 to 12,000 in increments of 400 RPMs, we do baseline, we ramp it down to 8,000 for the HeartMate 2 and up to 11,000. And if we see persistent aortic valve opening, a heart that remains significantly, it doesn't change significantly, and I'll define that, with a mitral inflow that looks like it's still the same, we think that's very worrisome for pump malfunction. So the cutoffs based upon this study was aortic valve duration, certainly less than 80 milliseconds. The LV size didn't shrink more than 0.6 centimeters. And I mentioned the acceleration time wasn't prolonged. So if you have 2 or 3 of these, the pump's not working. And we act on that clinically, and we'll take someone for more aggressive consideration for exchange or transplant. The last concept I'm going to go over in terms of clinical troubleshooting, then I want to get into our templates and then then open it for discussion, is LV suction events. And this can happen anytime. It can be influenced by the preload status, by the inflow cannula position, by the presence of RV failure. Patients can be asymptomatic or symptomatic with low flow alarms. But echo is very useful. In fact, early postoperatively, we use TEE upon activation to ensure we're not seeing excessive LV unloading or suctioning and we'll ramp down the pump speed. We'll do that similarly for those with concerning RV failure. When we're trying to optimize heart failure, you can imagine with an underlying ischemic etiology perhaps, an LV that's not big to begin with, you crank up that pump speed, you can get into a suction cascade that can be associated with ectopy or non-sustained VT. So echo could be very helpful in that regard. Please review all the details. There are established definitions for all these challenges in troubleshooting problems post-LVAD, and so the JACE document helps in that regard. So to keep it simple, there are typically 1 of 4 scenarios where we want an echo post-LVAD, and that's a surveillance study, and we at our institution get it typically post-implant around 2 weeks, 1 month, 3 months, 6 months, and at 1 year. If someone has persistent heart failure, left or right, or predominant right, an optimization study. In the setting of hemolysis, where we just want to know, is the pump working? And myocardial recovery, which is appropriately listed as 4 because it's an infrequent phenomenon, around 1 to 2% of our patient population. And so we have these protocols. Our LVAD coordinators know them, perfusion knows. I don't want to go through the details, but when we're screening, when we're looking to optimize, we have clear, agreed upon increments of testing in terms of which pump. The same thing for ruling out pump malfunction. So I'm going to skip these protocols. So these protocols are clear. So what helps us most, when the techs certainly put down the pump type on the image report, the pump speed being tested, the standard heart failure examination, which is a full echo, is going to be important. So here's a surveillance echo report, which I thought, I didn't read this. This was read in the echo lab. It's an excellent report. So it tells me the LV is small. They give me the dimension at this pump speed. They say the apical inflow is directed to the distal septum, so maybe a little bit off axis, but non-obstructive physiology. They give me the apical inflows, systolic and diastolic. EF still poor, which is anticipated. RV is mildly dilated, mildly depressed. They comment on the aortic valve, not open and we always want 3 to 5 cardiac cycles tested. They estimate filling pressures and give us the data that corroborates that assessment in terms of the patient's appropriately LV unloaded. And so this echo report we would think would be associated with a very, very stable patient. Now, I'd be a little bit concerned about how small the LV is, and we may back that down, but this is good. And so it's the standard echo report, but being cognizant of inflow velocities. Please provide the diastology or filling pressure estimate, which is similar to a heart failure patient, and commenting on the aortic valve function. So let's look at a patient that had smoldering heart failure. So it's the baseline findings with everything I said, and now we changed the pump speed. Now this was a historic example in that we were doing broad-based sweeps, 8,000, 9,000. These days we're doing 400 RPMs for the HeartMate 2 above and testing 4 cycles. And so you can give us the dimension aortic valve opening in MR, and that's going to help us tremendously. Now, typically we'll go back and look at it on our own, but a comprehensive report would give us LV size, MR severity, and along the lines of what you were asking, Dr. Zogby, in terms of a focused report. If we want to rule out pump malfunction or screen for pump malfunction, baseline and the 3 parameters that were most important, LV size, aortic valve opening status, and deacceleration time, at high and low. And no, I read this report, so I put everything in there. But you can tell us, there's a high suspicion for pump malfunction based upon these parameters. And this was derived here, and we've been using this clinically for years. So that helps us tremendously. I mentioned myocardial recovery. We similarly have defined echo, the role of echo, and we always lower the pump speed first and check before we commit someone to exercise and right heart cath testing. So this exists. I'm not going to spend time on it today. So what is needed? Before EPIC, we had the ability to say LVAD surveillance, LVAD heart failure optimization, LVAD rule out pump malfunction, LVAD recovery. And so we've had an open ticket, and in many ways I need to be more aggressive with following up with this, but we need to be able to write this in. And then the tech knows what we're looking for. They have that acquisition protocol. And then those reading echoes can answer the question on the report. And then the clinicians then have that, and it's a closed loop. So the only thing pending, and I think we're doing very, very good, is just finalizing the EPIC ticket with the specific LVAD indication. So echo plays a critical role. Changing pump speed, both for optimization and ruling out pump valve function is important. Echo remains first line, but let's hear from Dr. SU MIN CHANG about the role of CT in the lab. I gave you 10 minutes, right? I take 50 minutes and leave you 10 minutes. But this is, in fact, we're ahead of the game in so many ways compared to other institutions, but there's still some fine tuning on the back end.
Affected on fellows understand that seeing a beautiful not yet. So if you are plotting the pump at this stage of the game, you cannot tell you the plot inside the pump. Okay, so just go real quick. Doesn't matter. So this is a different component of the LVAD. So this will be a good positioning of the Harmony 2, okay? Inflow cannula pointing for the mitral inflow. So this is a good position there. This will be a normal outflow graph position, nicely straight all the way up. Okay. Now we have different LVAD. Again, this is an example. That creates some problem, obviously. Now the pump is attached right to the LV. That creates a lot of artifact, and we're actively working with Siemens in developing some software to get rid of those artifacts. Again, you can see that because of the position of the pump is different now, the outflow graph also is has different trajectory. So this is a typical good example of it. This is a hardware, and the outflow graph, instead of going toward ascending aorta, because of the surgical limitation, was placed in the descending aorta, which is an interesting case. Harmony 3 is being used more and more often, and this is what it looks like in the CT. Again, you can see the pump, the inflow directly attached into the LV apex, and the outflow cannula and the graft. And this will be an example of what we call band relief disconnection. I believe the patient has persistent heart failure and high power, high resistance. You can see clearly here, it's a disconnect. I think patient had to go back to have this exchange. Okay, so it's just some complication, patient with suction event and VTAC that Dr. ESTEP mentioned. As you can see clearly, this is one of the worst case of inflow cannula malposition I've seen. You can see essentially this thing is just stuck over septum, right? It's this is clearly the worst case you can have, extreme case, I should say. And this is another case with suspected suction event. And again, this is a different LVAD in the earlier generation. Again, you can see very clearly the myocardium inside the inflow cannula. And this is a very interesting case, and essentially this patient, every time he takes a deep breath, he has a VTAC. And we were able to see that when he was in a CT lab. You can see here, he was in sinus rhythm doing non-contrast scan, and but he might have took a deep breath or something. Doing contrast scan, he went to VTAC. And you can see this clearly again. This cannula was irritating the myocardium. And I think Jerry already showed this case, the patient was worsening. This was before the LVAD, this is after the LVAD, MR got worse. You can see clearly, Jerry already showed the echo. This is probably another worst case of cannula position. Basically, is interfering with the mitral valve apparatus. It's not unusual to see minor kinking of the outflow cannula because obviously there's some surgical limitation for the surgeon to put things in there. But again, this is extreme case, very rare. We've seen 1 or 2 cases from around 100 we've done so far. This double kinking, severe kinking of the outflow cannula. Okay, this case remains a little bit of mystery. Patient is really not doing very well. This is a non-contrast scan. You see air. Surgeon insists that's just part of the normal surgical finding, but I don't think it's normal to have air in the outflow cannula. I think the patient eventually expired after 1 month after this. So we never really find out what happened to the patient. But this is, again, very unusual. And this is a patient with recurrent bleeding from the driveline side, and what we found was there's an aneurysmal, pseudoaneurysmal formation in the anastomosis side of the outflow cannula. This actually appreciated better with 3D rendering. Okay, this here. And Dr. Bismuth went back there and he started jamming a lot of plug in there. And he said, oh, you can follow up, see we can see anything. Well, you cannot see anything once you put a bunch of occluder there, but I was told the patient stopped bleeding. So, all right, so this is another case, again, very, very uncommon. Basically, you have complete occlusion, thrombotic occlusion of the outflow cannula, okay? And this is a correlation, an echo of, basically, by increasing the speed, there's no changes in the size of the LV. So not only the outflow cannula is completely occluded, you can see there's also partial occlusion of the inflow cannula. So this is, the patient had to, again, this is a correlation and an OR, a patient went for explant. Jerry already showed this case, in patient was presented with a embolic event. I don't have a good case, but we've seen multiple cases. Now we're doing more dynamic study that actually you can see much less contrast flow in the ascending aorta compared to the rest of the aorta, right? Because you can imagine the flow now going here, going through the ascending, and here if the aortic valve is not completely, remain closed, it doesn't open, this will be stasis in the ascending aorta. So we can both see the contrast, less contrast in ascending aorta, and it also was proved by computational flow modeling that we've done over the last several years. And this is rare, but I think so far we have probably 6 or 7 cases proven by CT of aortic root thrombosis. Quite a few of them obviously cannot really be sure by echo. So basically, this is like a cases. It could, in the beginning, people think it mostly located in non-coronary cusp because there's no coronary there, but we show that it could occur anywhere, left coronary, like right coronary cusp. And obviously, surgical complication. Jerry mentioned about tamponade as very common. This is probably the most extreme cases that I want to show here. It's a huge, huge hematoma causing tamponade, and this patient had both LVAD and RVAD. And you can see there's multiple kinking also of the outflow cannula. So patient the OR. Anyway, this not from here. Luckily, we haven't seen cases like this of infection, air fluid level around the outflow cannula. I'm sure we probably have some surgical complication, but unfortunately, we haven't seen, really much cases of suspicion of infection. So when do we CT? I think this is summarized pretty well. When do you order CT? So basically, when you want to visualize a native heart and component of the LVAD, and especially when other imaging modality, essentially echo, is now revealing. Obviously, the other possibility could be doing a TEE if you want to look at inflow cannula and outflow cannula sometimes, but I think it's a lot easier to do a CT if the renal functions allows you. Just some quick example, RV function assessment now has become more and more, a lot more requests for us to assess RV function. I think the impression with HeartMate 2, HeartMate 3, now the pump is closer to the heart. Sometimes it's harder to assess the RV function. I think most of the cases, experienced echocardiographer can tell you qualitatively how the RV function is, mild, moderate, severe. But oftentimes we really are not so sure. We just say it's depressed. But if you want to do some research protocol, you really want objective measurement of changes, I think echo, especially transthoracic, is definitely deficient in the matter. And in the patient who can have a CT performed, like this case I'm showing here, you can get very good images, okay? You can calculate, estimate the LVEF. Basically, essentially, most of the echo parameters that you use to assess RV function, you could be used, CT could obtain that, even now the software to assess annular velocity, and I know people are working on SPEC, strain, looking at CT images with no surprise because it's really, the image quality is excellent. So, and this doesn't take too much time, basically. The software of the computer can do it within less than 1 or 2 minutes with minimal user interaction. And so this is more example of this. And this is a 3D rendering of the RV function. And you might see what's wrong with the picture here. And this essentially is one of those techniques that we'll try right now to decrease the radiation dosage. Just want to go back here, show you about the contrast dosage is very important because a lot of these patients have renal insufficiency. Again, with the newer scanner right now, you want to guess, let's see, 40 cc of contrast. If you only want RV function only, you don't care about the rest of the LV, we can do the RV function assessment with maybe 10 cc of contrast. If you just want to see the RV. And we can, and good thing is obviously this image here, you can see some faces looks clear. So basically we only want the best picture in systole and diastole. So you can decrease the radiation doses. And something that we find out right now, I don't have explanation. For instance, is this case is we can see right here, the RV wall is essentially fixed to the chest wall. And I've seen 2 or 3 cases in which RV is essentially, function looks depressed, but it looks kind of constriction-like. In this case, obviously, the septum is paradoxical, but has a pacemaker, pulse-off changes. So, but I think it's interesting. I will plan to collect more cases to see how this really, how often this kind of phenomenon happens, especially patient with, maybe this is the second chest operation. It is a more complication. Okay, this is another example. Anyway, so my question to my heart failure colleague is, from your experience, I know with Jerry we started this in 2011, 12 maybe, when we started doing first series of CT. Obviously, we only started with cases where patients have some complications. So the rate of abnormal findings obviously is biased and quite high. I think we had 18 patients. I think almost half of them had abnormal finding. One of the very interesting cases was patient who had persistent RV dysfunction and high PA pressure, and lo and behold, patient just have PE. And that would be very hard if you don't do a CT to find out. Obviously, we've been doing more systematically, I would say routinely, but we're doing more cases. Obviously, the abnormal finding is become less common. My question to you guys is, what kind of study we need to do to prove in this area, to prove that adding CT in the routine post-LVAD placement add any value to your management? Challenge.
That's an excellent question. So everyone knows that what's working. What we don't know is how CT prospectively redefine prevalence of different problems, and whether it will be additive in value. Because I'm going to be honest with you, RV failure post-LVAD is a clinical diagnosis, and we can typically troubleshoot it. When it's most overt and trying to delineate in half an hour regard, I would say there's probably no role for echo. But I do think its association with clinical outcome is wide open. I think how the RV is doing impacts functional capacity, impacts quality of life post-LVAD. And so I think there may be a role for CT and to come up with a study just to define association with better outcome versus worse to move the field certainly is worthwhile. But to get at what you ask in terms of its utility above imaging, inpatient versus outpatient, that would be very hard to do. And it would be perspective. The number needed to even define it would probably be a lot. And so I do think it's the second line imaging, like you mentioned.
Absolutely.
When we have when we can't answer the scenario with echocardiography, but when we need it, it's helped tremendously in these complex cases, and the frequency of that burden is much less than the routine, obviously. So I think there's a lot to be gained, and I know my colleagues are interested in CT. I don't know if you want to comment on what your thoughts on the RV and the role of CT, but certainly you're giving us beautiful images. Certainly you define the inflow cannula and outflow cannula, but it's still second line, and I don't think there'll ever be a study to along the lines of what you mentioned because of the challenges. Zabi, feel free to weigh in. I mean, I know you've looked at the role of DEFINITY on top of routine imaging, and certainly one can build a case. I mean, but
Imaging is difficult, particularly for the right ventricle, but just reading quite a few of these patients, of your patients, my concern is I see quite a bit of a high prevalence of RV dysfunction. And I haven't looked at it longitudinally, whether this is developing or developed, and you put it in an LVAD anyway, hoping that the RV will improve. But it is an issue, and it's hard for us to quantitate it and evaluate it because most of them are very hard to image, and particularly the apical window is difficult. Maybe parasternal window is easier because you're away from all the hardware. So that's one observation. The other question for you is, if you're suspecting somebody with a thrombus, either in the cannula or in the rotor, is it really safe to crank it up faster and faster to test and see whether the ventricle is short?
the HeartMate 2, there's this ruby red bearing, and one could be worried about propagation of clot in size. So that is a theoretical concern that makes a lot of sense with the biologic premise that's real. So what we mandate is with any ramp-up testing, they have to be on therapeutic anticoagulation, just to mitigate that risk. I personally have never seen it happen like in terms of sequelae, time-related with ramping up testing, but they have to have an INR that's therapeutic, 2 to 3, or on heparin with therapeutic PTT before we would do it. So I think it's a concern. Most programs continue to utilize ramp echocardiography, but it is in the presence of systemic anticoagulation.
Since the heart failure team is here, I think this is a good time to pose the question to you. There is point-of-care ultrasound nowadays, a little portable thing that you could have in your pocket, whoever is rounding, be it the fellow or the attending. And the question from a cost-effectiveness point of view, also timeliness for you, et cetera, et cetera. I could see in your service, I see quite a few echoes being ordered from you, is to have your own. And asking whatever particular question is, because to our eye, most of the time, the heart is exactly the same. The filling pressures are about the same.
The RV is still depressed?
Exactly, and that effusion that you're looking for is not materialized. No, really, I mean, I really think that, I mean, you know, obviously we have the expertise to help you in so many ways, et cetera. If you need a full study, yes. But that's part of the reason that I asked the first question, because you're there at the bedside. You know, you could dial in and take a look quickly, because even you don't need pulse Doppler, you don't need CW Doppler. You just need size and color Doppler and see what really happened to it if you have a good thing. But I would urge whoever I mean, I know you have new trainees in heart failure. I mean, heart failure and echo should be a
stethoscope,
marriage,
yeah.
because this is your, you know, I mean, that's how you're going to assess firsthand what your heart is like. So I'm going to pose that question to you guys.
So, no,
and I would urge you to start thinking about that, because obviously we could ask the echo lab to provide you one, provided that, you know, you fellows don't lose it and be deducted from your salary.
Yeah.
But
Yeah. So I think it's a timely question, important question. We incorporated some point-of-care testing with the handheld in the outpatient arena, because one of the issues we have is what's going on with the aortic valve and how accurate is the Doppler method to check blood pressure, wanting to know if the aortic valve was open or not. So I think that's two-dimensional, simple question, yes, no. So I think we could definitely use it in both the inpatient and outpatient once they get out of the unit. But some of my concerns relate to documentation and being able to re-review the data. And so has point-of-care testing evolved to be part of the medical record in any way in terms of interpretation and re-review?
not at this time. It's actually to help you, just like you use the stethoscope and I hear something, or I hear pulses, paradoxes, or whatever it is, right? All the auscultation, you know, it is a documentation of what you heard and what you've seen and what you've recorded. So if you feel, if you're on your round, said, oh, is the aortic valve opening on this patient because of, you know, whatever it is, so you take a look at it, said the aortic valve's open or aortic valve's closed, right? Or the LV is very tiny or the effusion is large. So at this time, it is not linked to your electronic health record, and it's not gonna be in a repository somewhere. It is your aid, and I think that's the question to you. You don't have to document everything with a picture, but if it is helpful to you, I think, and if we'll, you know, stop getting somebody with their machine on the floor and doing everything else, I think that's an aid for you, provided, number one, you're comfortable with the read at the same time.
So with that caveat, we would implement it both inpatient and outpatient, and I think it would minimize the burden of echoes we order. But I think for those standard full-time surveillance, the standard rule-out pump malfunction, we still want to be metric-driven, and the heart failure optimization, I still think that the vast majority of echoes you see will be there, but it would help. I think there is a cost effectiveness that we would be willing to buy into and implement tomorrow.
This is an important discussion because also a point of care ultrasound doesn't negate a full ultrasound. Do you understand what I mean? You see something that is of concern, said this is not the time to sit down at the bedside and do all the interrogation that you're gonna need. It is simple for structure, quick function, and color Doppler, nothing beyond that. So, you know, and me is just looking at the optimization. I think it's ideal if you have a good picture Oh, I'll take a look. Is the aortic valve open? What's happening to the right ventricle size-wise compared to the left ventricle? Function is not going to change. You're just going to look at size. And if MR is still torrential, or is it much better? It's simple.
Agreed. No, I agree with both of you. I think there's definitely a role, and especially both on inpatient rounding and outpatient. If not anything else, I think we can probably define the role of this for the whole field in terms of its use, because it's not, it has not been done, and maybe if if out of the 5 pictures you take, if there is one money image, we can probably even put it in the chart, because it shouldn't be too hard to import that into your note.
I was just going to say that he's on ICU now. I'm on wards next week. I'd be willing to try it.
Yeah.
You give me one, you give him one. Over 5 years, we'll let you know how it goes. We'll give it back.
Right.
But no, we'd be willing to try it.
So just a couple of comments on both those questions. I was just waiting so that everyone can give their input. So the first one, Dr. Zogby, I think that there is actually a role in a sense of even doing a pilot study like Ash is saying, because point of care testing with portable bedside ultrasound is not in use for LVAD population. So what happens is, at least for our index LVAD implants, initially the first few days we're optimizing them using right heart cath because we have a swan. Once the swan comes out and they're in the ICU and then they go to the floor, before they're discharged, when they're stable, they undergo a right heart cath / echo optimization study. That is a very reasonable, this is a real time what the filling pressures are. So if we can design a prospective study where we use bedside ultrasound, the portable ultrasound, to guide speed optimization, and then form a control group where we do not do that with our current care, then we can look at if it translates into, maybe it is useful and help when we actually do their right heart cath echo optimization prior to discharge in a stable state, that it leads to better unloading. Maybe it leads to better clinical decision making and also better cost effectiveness. And that way we can publish this and make a role of this in addition to using it clinically and reducing our echo utilization from a utilization standpoint. So I think that's very favorable. I'm actually personally interested. If that's how we want to do it, we can design a study to look into that. With regards to the CT role, the only thing I can add is that because I've worked with RV function, I know that RV function is a very strong marker of exercise capacity, and as we're doing more and more DT VADs, as a matter of fact, the majority of LVADs we do at our institution are DT LVADs. Our BTT population is very small. What's going to hold up over time is how their RV function behaves over time is what's going to decide what their exercise functional capacity is or what their NYJ class is. So with regards to that, echo imaging is very challenging. If you're ever going to publish this data and prove definitively that RV function is a powerful marker of exercise capacity, how are you going to do it? Because TAPSE doesn't hold up. It's really hard. RV fractional area change doesn't hold up. It really boils down to semi-quantitative RV function assessment by the echocardiographer. So I think in that light, because their images are pristine and you can measure RV ejection fraction, it would really weigh in on, it would be novel for our institution to publish a study like that showing definitively without any argument from the other side that RV function is associated long-term with exercise capacity and prognosis. That's my 2 cents on that.
Also, just to add to what you're saying, I think once, even if when we establish that we are able to truly differentiate somebody with, varying degrees of RV dysfunction, now it's, moderate to severe for pretty much everybody. But I think, getting a quantitative measure and also getting to know the level of ventricular interdependence, along with some hemodynamic parameters like we're doing right now, hopefully will enable a change in treatment paradigm, because right now all of our focus predominantly has been towards is really LV focused, where we are really not, looking so much in terms of the whole RV-PA coupling. We do a little bit, but not a whole lot. And that is where I feel we probably will have a role. I think it's too early, but once we establish that through CT, then the next step would be to see if we can potentially target it in a therapeutic manner to make their functional class and hopefully that even heart failure hospitalizations lesser.